Yeah, so this is something that we've been thinking a lot about. So somewhat ironically, and this has been the case for many, many years with cellular therapies, so if you hearken back to acute myeloid leukemia, which is sort of the sine qua non of patients who required stem cell transplant and cellular therapy in order to receive high rates of cure, the biggest barrier to long-term success for the past 50 years is simply a referral bias and a lack of transplantation. Unfortunately, that has extended towards CAR T, and so we know that it appears to have capped over the last 3 or 4 years that only about 30% or a third or so of patients who are eligible for CAR T, which is a curative intent therapy in relapse setting, actually end up getting it. The reasons for this are highly variable, and so I'd say that the main barriers come in simply human barriers. They're a referral bias, and that comes across both in terms of the referring doctors and the relationships that we have with them, but also I think as someone who's on the receiving end on the academic side, we can do a considerably better job of having relationships with our local partners, making access easier to us, making it much, much easier to contact us when they have appropriate patients, having a high commitment to sending those patients back to their referring physician when they're done with therapy. These types of just sort of custodial good efforts that you would do and what we should be doing as nice human beings, I think go a long way. The other pieces to the puzzle are often logistical, so getting patients transported over. I work in a state with a large amount of rural patients, and getting them in order to receive CAR T cell therapy and have them there for sometimes a month around our site is often a challenge, both from the travel back and forth as well as the logistics of lodging. So we have some of those problems fixed, but by and large those still persist for a number of patients. Another piece of that is simply caregiver concerns. So we require patients to have caregivers for the first 30 days of CAR T cells in case they have any untoward adverse events. That can frequently be problematic for people to come up with someone that's able to spend that degree of time with them. So there's a lot of those logistical barriers, but I would argue that probably the biggest ones happen within the doctors ourselves, and we need to do simply a better job of working with our colleagues who are referring in for cellular therapies.